Okay, hello everyone. My name is Hassan and welcome to tonight's session on benign prostatic hyperplasia and lower urinary tract symptoms. I'll just give it a couple more seconds for everyone to join and then we'll get started. Okay, that should be enough time. Let's get started. So our main learning objectives for today are to learn about the pathology behind benign prostatic hyperplasia, some of the symptoms you can get, and some of the ways we manage it. And at the end, we'll touch on the causes of management of urinary incontinence. And this is mainly in men. Let's get started. I thought we can get started with a warm-up. Let's say we're working in ED and a 67-year-old male presents with urinary retention. What do you think could be causing the retention? If you'd like to put it in the chat. Give as broad a differential as you can. Medication, that's correct, like anticholinergics. Amrita, thank you. Anything else? Urethral strictures, that's very true. That can cause retention, obviously BPH, which is the topic of our thing. Blocked catheter, yep. Stricturing again, infection, yep, in a UTI, you can get retention. Stones, unless they're very, very big, but normally they don't cause retention. If they were that big, they'd probably get stuck up higher in the ureter and not make it down through the bladder to the urethra. But those are a good differential. So our main one obviously is BPH, UTI, like you mentioned, hematuria and clot retention, and this is where you bleed, the blood pools in your bladder, it forms little clots, and this just blocks the opening of the urethra. We mentioned stricturing, medication like anticholinergics, alcohol. There have been some studies, and some people present, after binge drinking alcohol. Some men go into retention, and also neurological diseases. And this is where you have like impaired nerve conduction. You're unable to relax your sphincter. But mainly we're going to focus on BPH, benign prostatic hyperplasia. I thought we'd start off by talking about some anatomy of what essentially is the prostate. So this is an organ involved in reproduction, and its main function is to keep semen fluid so it can flow through and, in copulation, fertilize the egg. And it does this by secreting enzymes into the semen to break down clotting factors. And you can see in the diagram there the location of the prostate, just, in front of the bladder. I've shown another diagram here, and this is like a coronal view. So imagine someone's wearing a crown, it's cut right down, and you can see that the urethra sort of passes through the prostate, or the prostate sort of hugs it. And this is why, if it gets enlarged, it can cause symptoms. So what exactly causes BPH? And this is essentially proliferation of the cells that surround the urethra. So you can see from our diagram, in a normal prostate, the cells are normal size, there's enough of a lumen for urine to pass through. However, in BPH, the cells around the urethra enlarge and it blocks it up. And there's no exact cause, but it's thought to be due to dihydrotestosterone, which stimulates the growth of the prostate. And what you need to know about it is it's a steroid hormone, and it's made from the conversion of testosterone to dihydrotestosterone. And it's something we should park in the back of our mind for now because it comes in later with management. Main risk factors for BPH is old age. If you go to a urology ward, it's mostly full of old men because those are the people where BPH affects the most. Also family history, and also metabolic disease. So, I thought we'd do some epidemiology. Would you like to guess what the incidence is in men aged 60 to 70 years old? Like as a percentage out of 100? You can put it in the chat if you want. 30%, 40%, 20% for 60 to 70, 50%. Yeah, so we're getting higher. And let's say above 70, what do you think the percentage would be? More or less? $75? Yep, it's definitely higher. 70%? Yep. So if I show you the actual statistics, in 67-year-olds it's about 50 to 60%. Above 70, it's 80 to 90%. So you can pretty much guarantee that as a man gets older and he's above 70-year-olds, he will have some degree of prostatic hyperplasia. What do you think some of the common symptoms of BPH are? Bearing in mind that the normal way we pass urine is relaxation of the sphincter, compression of the bladder muscles, and flow through. So if we have a prostate which is narrowing the lumen, what are some of the symptoms, other than retention, you think we'd get? Poor stream, that's very true. It's one of the main voiding symptoms we get. Hesitancy, absolutely. So the main way we can break up the symptoms is done in literature. Frequency and urgency, very true, is if we look at storage symptoms and voiding symptoms. So storage symptoms, which quite literally is problems in storing the urine. So we have increased frequency, which is the need to go much more often. Nocturia, which is having to go multiple times at night. Urge incontinence. This is where you suddenly get the urge to go and you can't make it to the toilet in time, and so you wet yourself, and also sense of urgency. And then now if we go into voiding, this is where we get your poor flow, your hesitancy. This is incomplete emptying. You go to the toilet and you still feel like there's something left. Or terminal dribble, it just seems to keep dribbling out, as well as straining. So let's say someone comes to you in urology clinic and they mention these things, that I'm having trouble with my urine flow, it's very poor, I have terminal dribbling. What investigations do you like to do? How would you think we could diagnose it? This include bedside tests or imaging or anything like that. DRE, very true. Digital rectal examination. Anything else? Alright, so yeah, the main thing, the first line thing you do is digital rectal examination. So you gain consent, you wear a glove, or 2 gloves just to be safe, and you use some OptiLube, and basically what you're looking for is a prostate that's firm, smooth, symmetric, and enlarged. If it feels boggy or asymmetric, it's likely to represent a malignancy, but if it's smooth and enlarged, it's most likely BPH. Some more things we could do is post-void bladder scans, and this is essentially you ask the patient to urinate, and after urination you use an ultrasound machine to measure the volume of fluid left in the bladder, and you'd expect high residual volume. So even after they've been to the toilet, they've got 100, 200, 300 mils. You sometimes go up to a liter. And again, urodynamics, and these are tests to check the flow, and these help you diagnose it. But the thing is, they only give you clues. A true diagnosis of BPH is based on pathology. Essentially, with your previous tests and imaging, you can only really say that the prostate is enlarged. It's kind of hard to know unless you take samples and biopsies and send them off to the lab to see whether it really is BPH or caused by something else like a malignancy. So these are some images I put of pathology slides just to show you what the normal glands look like and what they look like when they've enlarged. Imaging is quite useful as well. A first line imaging would be ultrasound, and you can see it there in the red circle, enlarged prostate. And one of the main ones that's quite useful is MRI, or more specifically multi-parametric MRI. And there's something called the PRAD scale, which is, I believe, from 1 to 5, and it's used to tell you the likelihood that the prostate is enlarged due to BPH or malignancy. So the higher up the scale, the more likely it's malignancy, and the more likely you need to do some biopsies to rule out malignancy. So these are the main complications. So we've obviously touched on retention. If we move to hematuria, does anyone know why having an enlarged prostate can cause hematuria? So it's a bit of a tricky question, but the main thing is typically larger prostates are very vascular. You know, they have a lot of blood supply, which has helped them grow, and typically these blood vessels that form can get damaged quite easily, and you can get a lot of bleeding. Bladder calculi or stones are due to the fact that you can't empty your bladder, you get stagnant urine for a while, and this encourages the development of stones. And the main thing that we worry about is hydronephrosis or hydroureteral nephrosis. And this is essentially, if you have difficulty emptying, you raise the pressure of the bladder. And if you raise the pressure of the bladder, you can get backflow up the ureters to the kidney. And this causes hydronephrosis or enlargement of the kidney. So if you look at the MRI scan, as if we've cut through someone, you can see that the ureters, which are the renal pelvises, or pelvi, which should be quite thin, are very enlarged. And this can cause, you know, AKI, CKD, and that's the main thing we're worried about, and that's the main thing we want to prevent. So we've talked about, you know, what the prostate is, what can cause BPH and some of the complications. So we're looking into management now. And this management is to improve the symptoms as well as prevent hydroureteral nephrosis. So if we're looking mainly at symptoms of hesitancy, nocturia, urgency, and frequency, what we first recommend is reducing excess fluids during the day and especially before sleeping. So this particularly targets nocturia. So if someone complains that having to wake up 3 times, 4 times a night to pee, if they reduce the amount of fluids they take beforehand, there's less likelihood of them needing to pee. Caffeine and alcohol typically act as diuretics, make people pee more, so reduce them, you improve symptoms. Double voiding, which is basically spending longer at the toilet and trying to, you know, after the initial flow, void a bit more. And pelvic floor exercises, these can help a lot with incontinence and urgent incontinence as it strengthens the muscle and, you know, helps preserve the sphincter. Pharmacological, so lifestyle also includes catheters. So there's 2 options typically you can offer people. One is intermittent self-catheterization. You'll see that in notes written as ISC. And this is where you teach someone to basically self-catheterize themselves. And they'll do this, you know, a couple times a day. Can you think of anything that can go wrong if you keep catheterizing yourself, like multiple times a day for a couple years? Like any complications that can arise from that? Yep, very true. Stricturing, because you're putting in like a foreign body and cause inflammation and stricturing, and chronic UTI, or even just any UTI, the fact that, you know, you might not have the best aseptic technique and you're introducing bacteria. An alternative to this is a long-term catheter, which basically you put it on a leg bag. So instead of having it you know, attached to a urometer, you can attach to a small leg bag, and then you can just empty the leg bag in the toilet a couple times a day. One problem you have with long-term catheters is some patients can find it very uncomfortable. You know, penis is quite a sensitive region, you can get bladder constrictions, and it's quite painful. So what we do for these patients is you can offer them a suprapubic catheter. And this is basically where the catheter goes through the abdomen just above the pubic bone, and to be honest, it's the same design as a regular catheter, but it drains through there, and it's typically less symptomatic and more comfortable. And our main aim with catheters is to keep pressure low and protect your kidneys. So these are some of the lifestyle managements we have. Does anyone know any medications we can use to help with BPH and some of its symptoms? Would you just like to put them in the chat? Tamsulosin, very correct. An alpha blocker, typically the first line thing you try. Any other medications? Finasteride, yep, absolutely. And that works with the thing we mentioned about hormones earlier. Great job. So, if we start off with tamsulosin or alpha blockers, and these basically antagonize the alpha adrenoreceptors and they relax the smooth muscle of the prostate. So the muscle relaxes, you get a slightly wider lumen, and you improve flow. Typically, these work in 2 to 3 days. So if you have a patient on the ward, they've come in with retention, you've put in a catheter, and you start them on the medication, it won't work instantly. So you need to wait 2 to 3 days, and then you can try a trial without catheter. It's not without its side effects. The main thing is it can get dizziness due to hypotension, because basically it works on receptors in blood vessels and causes vasodilation, which drops your blood pressure, and also retrograde ejaculation. And this is essentially where, instead of ejaculating out of the penis, you ejaculate into the bladder. And those are some of the side effects. Moving on, we have finasteride or dutasteride. My hospital seems to like finasteride more, and this is a 5-alpha reductase inhibitor. And we mentioned earlier that one of the potential causes of BPH is testosterone gets converted into dihydrotestosterone, which increases proliferation of the cells. This blocks that, and so you have reduced dihydrotestosterone and less growth. This, being a hormone, takes a lot longer to work. Typically 6 to 12 months. So you have to explain to patients that it's not going to work as quickly as tamsulosin. You have to persist with it to get some benefits. Some of the side effects, you get reduced libido and weaker erections. One of the things which is actually good is it improves alopecia. So some men take finasteride if they're losing their hair. One thing to bear in mind is it reduces the normal value of PSA, which is a blood test we use, and we only use it to kind of screen for cancer, or you're suspicious of cancer, you check the PSA. So if a patient is on finasteride, it normally reduces the value to half, so you have to watch out for that if you think of diagnosing a malignancy. Another type of medication is anticholinergics like solifenacin, and these help with symptoms of like urgency and frequency, because they reduce bladder activity. They antagonize muscarinic receptors, and it calms down the bladder, so you reduce the urge to go that often. As they are muscarinic receptor antagonists, they cause dry mouth and constipation, and most importantly, if a patient has glaucoma, you can't give them solifenacin because it can worsen their glaucoma because it acts on the muscarinic receptors. Another type of medication is mirabegron. Does anyone know why we would use mirabegron in a patient who has a catheter? It's a bit of a tricky question. So you give a patient, they're on a long-term catheter, and they're getting some type of symptom, and we give them mirabegron for it. Do you know what symptom they might be having? Okay, a bit of a tricky question. It's bladder spasm. So in some men, you put catheters in and they get really painful bladder spasms and contractions. And Mirror can help with that. Maria, it also helps with urgency because it relaxes the detrusor muscle and increases capacity. The problem is it can also cause constipation and UTIs. Yep. One thing to point out when you're looking at treating BPH is that once you have a patient who suffers from both urgency and frequency, so they're having to go very often, very urgently, it's likely too late for surgery, and surgery at this point won't help them. And so if you're ever managing it, you need to, for most people, surgical intervention will be the ultimate management, so you need to try to operate before it reaches that. So if we move on to surgery, does anyone know any type of operations you can do for BPH? Would you like to list them in the chat? TURP, yep, that's very true, and that's the first one I've got, TURP, and this is a procedure where basically you insert a scope through the urethra of the penis. It has a little camera, and you can visualize the prostate, and what you do is you slowly shave off the inner layer of the prostate, and this increases the lumen because naturally you've removed some of the volume of the prostate and can help improve symptoms. So that's basically what a TURP is. It's very, very common in urology. It's quite a good elective procedure, and typically the patient can recover quite soon and go home the same day. However, a TURP isn't useful when you have a very large prostate, like more than 100 cc's. Does anyone know any other procedure you can do for someone with a very large prostate? Okay, a bit of a tricky question. The main thing is HOLEP. So I don't know if you ever spent any time around urologists or urology regs, HOLEP is the main thing they talk about. They're obsessed with it, mainly because it has quite a big private market, and you can charge like $7,000 for it. But HOLEP is quite important because it can let you operate on people with very large volume prostates where a TURP isn't useful. So it's called a HOLEP because you use a holmium laser. And the basic idea is, if you kind of look at the orange peel, is the prostate sort of has a capsule that surrounds it. And so what you do is, with your laser, you just cut off pieces inside of the actual prostate tissue, but just leaving the capsule behind. And once you cut these small pieces, you sort of push them into the bladder, and then you do a process called morcellation, where you pull this tissue through. And HOLEP has many advantages. So typically, you can do it on bigger prostates. It can be a very quick operation, half an hour. You have reduced bleeding. You have improved outcomes, so less likelihood of incontinence. And so it's a really great operation to do. The only problem is it has quite a progressive learning curve. You have to do quite a lot of operations before you get good at it. But HOLEP is one of the newer treatments and quite useful. One of the older treatments for BPH is a simple prostatectomy, which is just removing someone's prostate. It's also done in malignancy when you have prostate cancer. And this can be done open, like through an incision in the abdomen, or more commonly these days, robotically. And this is where you basically remove the prostate and plug, and you basically make an anastomosis between the bladder and the urethra. And so it has its obvious downsides. It's a longer operation, it's more invasive, there's more chance of infection and more chance of bleeding. It'll also have a longer recovery period. And you still risk things like incontinence. So it's less used these days. And so in a summary of like the surgical procedures, the main things you do is TURP and HOLEP. TURPs are quite common, done pretty much everywhere, and they're used for smaller sized prostates. HOLEP is newer and used for larger sized prostates. And typically you can do the procedure within an hour, half an hour, and send the patient home with a catheter. And at a later date, you can send them for a TWOC, or a trial without a catheter. So TWOC is something quite common you see on urology wards, and to be honest, in loads of wards for anyone who's catheterized. Does anyone know how a TWOC, or a trial without catheter, would be successful? Does anyone know like the procedure behind it, or what makes a TWOC successful? Passing urine within 24 hours. That's a part of it, but the main thing we care about with a TWOC is how much urine are they passing and how much is left in the bladder. So a successful TWOC would be you pass a good amount of urine and there's very little left in your bladder. And this is the way you do this is you measure urine output. So they pee into a bottle and you measure it, and also every time they pee you do a bladder scan with an ultrasound machine to check how much is there. So a successful TWOC would look like something along the lines of you pull out the catheter, in the next few hours they pass urine twice, they pass 200 to 300 mils, and in the bladder there's less than 100 mils left, and that would be a successful TWOC. An unsuccessful TWOC would be they pass very small volumes, like 50 mils, 70 mils, and the main thing is the residual volume in the bladder goes up. So after urinating 3 times, the residual volume in the bladder goes from 100 mils to 150 mils to 200 mils. And this shows that they're just retaining and retaining, and they'll go back into retention. And in that case, you'd have to put the catheter back in and try it at a later date, or try some medications. That's something quite important. You'll see it a lot on the wards, like elderly care wards, any surgical ward. And it's mainly about trends. Is the residual going down, and are they passing good volumes of urine? So that kind of covers BPH, how we diagnose it, how we manage it, and now we move on to incontinence. So incontinence, a simple definition, is just an involuntary loss of urine. And you can kind of break it into separate categories. So first you'd have stress. So this is when you have raised abdominal pressure, you lose urine, sneezing, coughing, exercising. And this is mainly due to weakness of the sphincter. So it's too weak, at high pressures it fails. Another type is urge incontinence. And this is, you're just chilling, you get a sudden urge to urinate, and you can't get to the toilet in time, and you make a mess. And this is typically due to overactivity of the bladder muscle. And finally, you have overflow incontinence. And this is seen typically in high pressure chronic retention in BPH. So you'll have a man in his 80s, he's had BPH for a couple months, passing less and less urine, and he's got quite high pressure, and so the pressure will eventually lead to some urine passing out, and this will typically happen at night. And that's one of the main tells, is if a patient comes in and they say, I have incontinence at night, it's normally from chronic urinary retention. So the way we manage incontinence, first of all, with diagnosis, it's very helpful to get bladder diaries. And this is, you encourage the patient to talk about, they note down every time they've had incontinence, every time they've passed urine, and basically what's happening. And again, urodynamics helps with the diagnosis. So for someone with stress incontinence, which is where someone with stress incontinence, the main things you do are starting with weight loss and physiotherapy. So physiotherapy would include things like pelvic floor strengthening exercises, and this helps improve the sphincter and tries to reduce the symptoms. You have some surgical procedures. One includes passing a sling, and that kind of acts as your new sphincter. Or you have an artificial urinary sphincter, which is actually quite cool, where it's like an open surgery through the scrotum, and you have a small device which uses like a liquid and pressure, and it keeps the sphincter closed. And when you want to pass urine, you can open a valve or play around with the liquid, and it relaxes it or opens it, and you can pass urine. Urge incontinence, you typically use medications like we've mentioned, some anticholinergics or things like mirabegron. Again, you can do pelvic floor exercises, or sometimes you do Botox injections, which is a surgical procedure under general anesthetic where a surgeon goes in and injects Botox, and this relaxes the muscle of the bladder and prevents it being overactive. Overflow incontinence, the main way you treat that is you treat the BPH. So you can give someone a catheter and this gives them some control, but mainly you want to treat the BPH. So, just to summarize what we've covered today, BPH affects the majority of men over 60, above 70 it's approximately 80 to 90% of men. The main treatment, you can have lifestyle treatments such as, intermittent self-catheterization or using drugs, and finally surgery, which will be a more definitive management. And lifestyle measures in patients who are not fit for surgery can improve their quality of life quite a bit. So you should never rule them out. And that's the end of our session. Thank you for attending. I'd appreciate it if I get your feedback on how you think the session went. And if you have any questions, you can put them in the chat. Oh, you're welcome. Thanks for coming. Thanks for coming. Hope you found it useful. I can also put a link in the chat, just in case you don't have your phone. And I can also link the next urology session I'm doing if you want to register, and it'll be on stones, which is quite a common topic and quite commonly presents on the wards. And also we have a really good session by one of my colleagues on HPB surgery tomorrow, so there's the link for that as well. If you'd like to sign up, I think it'll be really good. Quite a high yield topic for exams. Okay, well, if there's no more questions, I'll say goodnight to you all. Hope you have a good evening, and good luck with your revision.